Chronic heart failure. Heart failure is a clinical syndrome in which the heart is unable to pump sufficient blood to meet the metabolic demands of the body. It may result from structural or functional cardiac abnormalities that impair ventricular filling or ejection. Epidemiology. Incidence increases with age and is most common in adults aged 70 years or older. Risk is higher in individuals with cardiovascular comorbidities such as hypertension, ischemic heart disease, diabetes, and atrial fibrillation. Pathophysiology. Heart failure can be due to impaired ventricular contraction, systolic dysfunction, impaired ventricular relaxation, diastolic dysfunction, or both. Left ventricular dysfunction leads to increased pressure in the left atrium and pulmonary vasculature, resulting in pulmonary congestion and symptoms such as dyspnea and orthopnea. Fluid accumulation may also present as peripheral edema, including sacral or ankle swelling. Heart failure is classified into heart failure with reduced ejection fraction less than, for example, 40%, and heart failure with preserved ejection fraction over 50%. In heart failure with reduced ejection fraction, reduced stroke volume and cardiac output activates neurohormonal mechanisms, particularly renin-angiotensin-aldosterone system and sympathetic nervous system. Initially compensatory, these pathways eventually contribute to fluid retention, vasoconstriction, and ventricular remodeling. Symptoms: dyspnea, exertional or at rest, orthopnea, paroxysmal nocturnal dyspnea, persistent cough, which may produce pink or frothy sputum, fatigue, peripheral edema, ankle and sacral, cold peripheries, and weight loss or cachexia in advanced disease. Signs. Signs of chronic heart failure include bibasal crackles on chest auscultation, raised jugular venous pressure, hepatomegaly, S3 or S4 gallop rhythm, displaced apex beat, hypotension or narrow pulse pressure, tachycardia, and peripheral edema. Investigations. History and examination are essential to identify signs, symptoms, and possible causes of heart failure. Blood tests include NT-proBNP. Over 2,000 nanograms per litre warrants an urgent referral to cardiology within 2 weeks. 400 to 2,000 nanograms per litre requires referral within 6 weeks. Less than 400 nanograms per litre means that heart failure is unlikely. Other blood tests include full blood count, UNEs, LFTs, TFTs, lipid profile, and HbA1c. An ECG can be used to assess for arrhythmias, ischemia, or previous infarction. An echocardiogram is the gold standard for evaluating structural abnormalities and measuring ejection fraction. Chest X-ray may show cardiomegaly, pulmonary edema, or pleural effusions. New York Heart Association (NYHA) classification. This is used to assess the functional limitation. Class 1, no limitation on physical activity. Class 2, symptoms with moderate exertion. Class 3, symptoms with minimal activity. Class 4, symptoms at rest. Complications. Complications of chronic heart failure include pulmonary edema, chronic kidney disease, stroke due to thromboembolism or atrial fibrillation, arrhythmias, for example atrial fibrillation and ventricular tachycardia, and sudden cardiac death. Management. General measures include cardiac rehabilitation, group-based education, lifestyle advice, and supervised exercise, vaccinations, annual influenza and one-off pneumococcal vaccine. Lifestyle, salt and fluid restriction, smoking cessation, weight monitoring, and alcohol moderation. Symptom control. Loop diuretics, for example furosemide, can be used for fluid overload. It is important to monitor for electrolyte disturbances and renal functions. In heart failure with reduced ejection fraction, the first-line pharmacological therapy is an ACE inhibitor or ARB if ACE inhibitor is not tolerated, or a beta blocker, for example bisoprolol or carvedilol. Add-on therapies may be used if symptoms persist. A mineralocorticoid receptor antagonist, for example spironolactone, with monitoring for hyperkalemia. SGLT2 inhibitors, for example dapagliflozin, can reduce hospitalization and mortality even if the patient is non-diabetic. Sacubitril valsartan can be considered in place of ACE inhibitors in symptomatic patients. Ivabradine can be used for patients in sinus rhythm with a heart rate of over 75 beats per minute despite a beta blocker. In heart failure with preserved ejection fraction, there is no proven disease-modifying therapy. Focus should be on optimizing comorbid conditions, for example hypertension, diabetes, and AF, symptom relief with diuretics for fluid overload, and consider ACE inhibitors or angiotensin receptor blockers and beta blocker if not already on.
That was just a preview. Watch the full video and hundreds more at finalmed.co.uk. Get over 9,000 UKMLA exam questions, hundreds of animated videos, and our trusted textbook all in one platform designed to make your revision faster, clearer, and exam focused. Start your free 7-day trial today